Thank you, organizers, for inviting me here. I'm honored to be here. Now, when these topics were being discussed, I was also involved in it, and somebody did make this suggestion that we should have something on clinical rounds. At that time, I didn't expect it to come to me, okay? Because generally, we anesthesiologists don't conduct clinical rounds, unless it is in an HTO or an ICU or someplace. So I had to look here and there and try and find something. So I thought ICU might be a good place to start, because that's one place where we generally conduct some sort of a clinical round, and then it's usually a multidisciplinary kind of a. So slides are visible? Okay. Now, basically what you do during the clinical rounds is do a review of the clinical information. You take the history, you put all those things together, and then at the end you develop a plan for the patient about how he should be treated or what are the changes that you should bring about in the treatment part. But above that, there's another important function. It is actually a training ground for the resident. It's actually an educational thing for the resident too, okay, the junior resident. It can either happen at the bedside or in a conference hall, but generally it's at the bedside itself, unless in very special situations you may want a special conference room for discussion. Now this is important. There's no gold standard. There's no particular structure that is set for that. And because of that, we need to tailor it to our local requirement. And there have been many suggestions, like a minimum standards that every patient under care of a particular consultant should be seen at least twice a day. I don't know how many of us do that. And you have to set a management plan on a daily basis and have a structure based on your local requirement. So what makes an effective clinical rounds? Remember, it's basically a multidisciplinary kind of thing. So there are multiple people coming in, and it's basically a collaborative discussion rather than finding fault, pointing out mistakes. Yeah, it's important to point out mistakes, but then you don't blame people for that. That's a point where you correct your juniors and go on. Unless it goes like that, it doesn't become constructive. It becomes more of a useless kind of an affair at that point. And another important point is that suppose you have an ICU with about 8 beds or 10 beds. How long are you going to spend with each patient? So that time wasting should be minimized to as much as possible. You should have access to all the patient data, because we need to look at the investigations, you need to be able to look at the images, you have to have histories, you have to see the various other consultations seen by others. So you should compile everything together. So that should be available. And then collectively you discuss and document the goal. Again, you should have a standardized structure based on how you want it. It's always a good idea to use checklists. And ideally, if you have a pharmacist, it's good. I'll come to that a little later, why it's important. The nurse involvement is also very important, because they've been with the patient throughout. The last 24 hours, the patient has been with us. The nurse has been with the patient. And every change that has happened, they would have noticed, if they are clever enough or alert enough to notice that. And most of the changes that happened over the post 24 hours is usually gleaned from the nurse himself. Now, coming to the checklist part, in 2005, Jean-Louis Vincent, he came out with a checklist, and he called it, give the patient a fast check on a daily basis. Okay. What it actually means is that basically these are some of those key issues that we generally tend to miss. And it's a mnemonic. It goes like this. Fast check, F goes for feeding and fluid. So you look at the patient's intake, output. Is the patient getting fed? If not, if the patient's NPO, are we giving fluids? Is enough nutrition going in? That kind of things. Then come to the analgesia part. Another point we may actually neglect. Okay. Is the patient having enough pain relief? Coming to sedation. Is the patient too anxious? Are we giving sedating the patient to keep her calm down? Thromboprophylaxis. If the patient is in bed for long, are we doing something about that? If the patient is on a ventilator, is the patient's head end elevated? Are we giving ulcer prophylaxis? Are we taking care of the glucose control in an ICU patient? So this is very important, because if you have this checklist, you, after having looked at the history and investigation and everything, you also make sure that this is taken care of. Okay. The importance of pharmacists, although we don't have pharmacists with us always, these points are very important to remember. The average hospital patient is subject to at least one medication error per day. Just imagine what might happen to patients. And medication reconciliation is a major component of safe patient care. Now, what I mean by medication reconciliation is, the patient comes from the ward, they have a set of medication that the patient is on. Now the patient undergoes the surgery, during which time you're not giving any medicine. Post-operatively, what are the medicines to be continued? And when you write, like you write it from the chart, from the, looking at the previous list of medication, you write down to the chart here, you make mistakes. So make sure all those things go seamlessly without any problem. And then the added medications, okay. And the same thing should be continued into the post-op period also. And that's the reason why we need something like a pharmacist who look after those things. In addition, this is the other advantage, they can identify any drug errors that happens. They can help with dose adjustments. For example, somebody with a renal failure, do we need to adjust the dose? Are you going to remember all the drug dosages in your life? No, we need people to help us with that. It makes our life much more easy. Drug interactions, antimicrobial de-escalation. Again, they are the people who can help us with that. Okay, so this is the importance of having a pharmacist with us. Now I'll just take you through some cases which have happened. I may have modified it here and there a little, but then this is a 67-year-old lady who undergoes a CA buccal mucosa resection. Okay, neck dissection and reconstruction with a pectoralis major flap. So it's a major surgery. It takes about 5-6 hours or so. Now the patient is shifted with a tracheostomy because there's a bulky flap sitting in the oral cavity, and she's on mechanical ventilator at this point. On NORAD support, but the blood pressure is kind of borderline. Now coming to the background of this patient, she's got rheumatic heart disease with mitral stenosis and mitral regurgitation. She had, and she underwent a mitral valve replacement. Currently, her status is stable. She's been diagnosed as stage 3 CKD with adequate urine output, creatinine is 1.9. Okay, electrolytes are normal. Surgical time is close to about 5 hours. She's mildly hypothermic, so we decided to ventilate this patient overnight. Intraoperatively, the patient has been unstable. They tried managing with fluids, but the patient's blood pressure didn't come up, so NORAD was started because you know that the patient is a chronic renal failure patient. It's easy for us to push them into an acute on chronic renal failure, so you need to prevent that. Right? There's no significant blood loss or anything intraoperatively, so no transfusion requirements. Now, when you come to the assessment of the patient on that day, you go by systems, like you go to the CNS. You don't have to do an extensive workup of CNS. What you do is, okay, is the patient conscious? Are they obeying commands, moving all limbs? Is the patient on sedation or off sedation? Okay, they've stopped sedation since 5 o'clock because they want to assess the patient in the morning. Coming to the respiratory system, you're not going to do all those percussion, palpation, and all those things. No. You have a mechanical ventilator, so go by that. So coming to the respiratory system, you look at the mode, okay? It's an SIMV, volume control, pressure support. What are the FiO2? It's come down to 0.4, so it's okay. Saturation is about 100%. Peak pressure is only 14, so it's not a very demanding kind of chest. Tidal volume achieved is 390, which should be okay for her. PEEP is 6, respiratory rate is 16, comfortable breathing. Chest is clear in all fields. That is something you should do. Make sure you auscultate all the fields. And the patient is triggering ventilation, which means that she is fully able to breathe on her own. Coming to the cardiovascular system, again, don't do an extensive, look at the heart rate, look at the blood pressure. There's an arterial line, so the blood pressure is 120 by 68. On NORAD support, it's only a minimal support, 0.04 mics per kg per minute. Pulse are felt in all limbs, no arrhythmias. So that's all you need to know. Unless you have a specific reason to look for, just do only so much. Coming to the general examination, do a head to toe quickly. Patient is afebrile, you look at the eyes for any changes. Look for maxillary tenderness, because any patient in the ICU who's had a Ryle's tube or a nasogastric tube for long, make sure that you check that, because that's one of the site of infection for them. If they have tenderness, you need to look at the maxilla for any sinusitis. Oral cavity, there's a bulky flap sitting there. Look at the lines, very important. There's a right radial arterial line. You have to check for warmth and color of the limb. This is very, very important. The patient's got a mini midline catheter in the right basilic vein, site is clean. So again, the site of insertion should be checked in each patient. There are two additional peripheral lines, one on the right, great saphenous vein in the leg. Okay. Now, abdomen is soft, non-tender, not distended. Back, you should always check the back for any skin peeling or any developing of any bed sore. Because if the patient is going to stay there for a week and you don't look at the back, at the end of the week, when you're about to shift the patient to the ward, you will find it also there, or a bed sore. So that's again important. Patient got a Foley's catheter, lower limbs look okay, no edema, no tenderness, no redness. It is not important to look at the leg on the first day, but if the patient has been in ICU for several days, it's important because they may be developing DVT. Then you come to the medication, look at the medication list. Okay, analysis is going, proton pump inhibitor going, antibiotics. Should we continue it? Something to be considered. Is the patient getting prophylaxis? Yes, low molecular weight heparin is going. IV fluids, the nephrologist has restricted the fluids to 1,800 ml, so is that going properly? Right. Then you come to the investigation. So you take each one after the other and look at it. Now, among the investigations, although everything looks okay, potassium has gone up by about 5.8, which is a little alarming in this patient. Blood gas, good PO2, PCO2, everything is okay. Blood glucose looks okay. Coming to the images, see, when you look at the X-ray, the important thing is to look at the lung fields, also look at all the lines. If you put a nasogastric tube, is it in position? The patient's got a central line, is it in position? Okay. If the patient's got a tracheostomy tube, is it gone too far into the right side or something like that? So check all those things. And in this patient, you can see the mechanical prosthetic valve also. Coming to the checklist, we don't want to miss anything. So feeding, okay, the patient is on IV fluids, kept NPO currently. Yeah, you can consider starting feeds today. Analgesics, what's the plan? Okay, you're continuing with paracetamol. For breakthrough pain, you can try fentanyl. Sedation, it is stopped early in the morning. Shall consider restarting if required. Coming to thromboprophylaxis, the patient is getting low molecular weight heparin. We may have to consider Stockins if the patient is going to stay in bed. Head and elevation, yes, that's happening. Ulcer prophylaxis, the patient is getting it. Glucose control, glucose is being monitored. Now, what are the problems here? We have hyperkalemia, which needs to be addressed. Does the patient need mechanical ventilation? No. The patient is awake, alert, and everything, breathing comfortably. For the tracheostomy, do we need to do anything specifically? Can NORAD be tapered off? Lines. Can any of the lines come off? Can we think of ambulating the patient today? Can we start feeding and prevent any renal dysfunction from happening from this? So, looking at hyperkalemia, you need to address that. So, you start the patient on some GI bolus. That's a plan for today. Salbutamol nebulization, maybe add intravenous furosemide 20 milligrams as a bolus and then switch to oral. K-bine can be added. And the nephro guys wants to add some soda bicarb tablets also. And again, the plan is to check the potassium in the evening to see if it's come down. Coming to mechanical ventilation, you can consider weaning today because there's no actual demand on the respiratory system as such. Tracheostomy. Now, once you disconnect from the ventilator, the patient's humidification mechanism is completely bypassed. So we need to add some sort of an HME at this point. Oxygen, yeah, oxygen to keep the saturation just above 94. So, can NORAD be tapered off? It's important that you maintain the perfusion pressure. We don't want the patient developing renal failure. So watch that, taper it off slowly. But if required, you can continue for another 24 hours. Lines, yeah, retain the arterial line because we'd like to have a closer look at the blood pressure. Remove the venous line from the leg. We don't need that. And retain the catheter for one more day. We'd like to look at the urinary output. Maybe we can think of adding a TED stockings. Ambulation can be delayed for one more day because all catheters, lines, everything in. And you can consider starting with feeds today. Avoid any drug that may damage the kidney. That's where the pharmacist might help. Also, your knowledge can also help a lot there. So that's one way of doing it. Now, it should not take too much time. When you do this, maybe about 10 minutes or 15 minutes when the patient is sick. Coming to the second case, it's a 70-year-old lady, post-ventral hernia repair on epidural bupivacaine. Re-entry on POD2 to ICU with breathing difficulty and desaturation. Now, background is a bronchial asthma. She's on inhaler. On admission, drowsy but arousable. SpO2 is 85 on 12 liters of oxygen. NIV was initiated. SpO2 peaks to about 96%. But the ABG done shows something alarming. pH is 7.18, PO2 seems okay, but then PCO2 is 79. Okay. So it's an acute respiratory acidosis. There's no point waiting and trying NIV and all those things. Straight away go and intubate because we have some irreversible conditions there right now. The issues are the patient's got a distended abdomen. They do an ultrasound and find that the large bowels are all dilated. So it's paralytic ileus. There's a big incision, so there's possibility of a basal atelectasis. There's a background of asthma. There's a bit of wheeze all around. And in addition, the doctor, the surgeon has actually added a buprenorphine patch, a 10 mics patch at the back. Now the problem is when putting everything together, this could be the reason why the patient has gone to a respiratory acidosis at this point. Okay, so we are unable to come down on the FiO2 at this point, and the peak pressure is very high. So the measures done are, you put an NG tube, you remove the buprenorphine patch, abdominal binder is removed, abdominal girth is being monitored, sedation, we start with dexmedetomidine. We don't want any narcotic going, so epidural analgesia is continued for the pain part. And then the bronchodilators are continued, antibiotics added. You add a closed suction because the moment you disconnect the patient starts desaturating. So that's what you do. So the rounds is happening on day 2. At about 4 a.m. in the morning, the patient actually desaturates. And the tidal volume is not being achieved. Tidal volume, which was somewhere close to 400, suddenly drops to 170 to 250. Airway pressure is high in spite of pressure control ventilation. The ventilator graphics is distorted. Patient is sweating, tachycardia, hypertension, and then chest, when you look at it, crepitations all over. The patient who was comfortable suddenly comes into this kind of state. Okay. On inspection, the circuit is waterlogged. Okay. Everything else looks okay. You check the ventilator separately, it looks okay. Now, when you look at the circuit, it's waterlogged. There's no water trap there, and the filter at the expiratory port of the ventilator is clogged. Okay. The filter is replaced, water is removed, patient is sedated with fentanyl, and now it's comfortable. Now, when we come for the rounds in the morning, patient is afebrile, looks okay. We look at all those things, maxillary tenderness, NG tube position, there's no pus in the nose, oral cavity looks dry, endotracheal tube. Again, every day you check the patient's endotracheal tube, see the point where you have fixed it to see if there's any skin change happening there. Because sometimes when you fix it in such a manner, sometimes there can be some necrosis happening there. Abdomen is distended, tense, there's some air in the large bowel. Back, no skin tenderness, peeling, there's no redness, all pressure points are clean. Coming to system, respiratory system, high peak pressure on VC mode, switch to pressure control, assist control mode. VT achieved is 370, respiratory rate is about 20, pH is within normal limit, PCO2 has come down. Humidifier is added, and come to cardiovascular system, blood pressure is okay, heart rate is okay, patient is alert and obeying commands now. Checklist, again, we'll continue to keep the patient NPO, IV fluids about 100 ml per hour, epidural analgesia being continued, dexmedetomidine continued, low molecular weight heparin fine, head and elevation, ulcer prophylaxis, glucose being monitored. So when you do all these things, you make sure that the patient's care is being taken care of. Coming to medication, you look at all the medications, see anything that needs to be added further. Okay. Coming to the investigations, look at the chest. Now today there's a new patch developing in the patient, so we need to consider a ball to be sent